Oh, hello. I'm hoping. Yep, I am recording. So, hello. We're going to go over chapters 5, 6, and 7 in anticipation of the quiz. Once in a while, I might look over here and check the quiz out just to make sure I'm covering every bit of information for you for the quiz. So, without further ado, I'm going to share my screen. Wait, and we're going to talk about chapter 5. Oh, there I am. Okay. Chapter 5 from the beginning. Start at the top. Oops. All right. So this is a chapter about therapeutic relationships. Um, just go back. Yeah, therapeutic relationships. And there's a lot of concepts that go with therapeutic relationships that you need to kind of understand. Um, and we've already talked about a couple of the buzzwords from chapter 3 and chapter 4. So if you have any questions, please email me. The relationship is something that it takes a while to build with someone with mental illness because they innately don't trust. When you can be empathetic or genuine enough to establish a trusting relationship, you're going to be able to do the most work with that patient. Again, trust, very, very important. It's manifested by a genuine interest and understanding, a consistency, listening, active listening to your patient. And there's the box for you in the chapter. And trust also is being congruent between your verbals and your nonverbals. So if you are really interested in someone, you should be leaning into them and speaking with them while maintaining or at least looking like you're maintaining eye contact, and that will help you build a trust relationship. That genuine interest is you're listening to them. You're really listening to them. Most people can tell when they are with someone they can't trust or someone who's not interested in what they're saying. So building that relationship starts here. And then we talked about empathy, empathy being feeling with someone versus sympathy, which is feeling for someone. And we have unconditional positive regard and acceptance. Basically, we accept everybody for who they are, regardless of their circumstance, regardless of what they look like, regardless of everything. So, you need to know yourself. You need to know what values you possess, what values you choose and you consider most important to yourself, what you believe, um, like, do you believe in same-sex marriages, or is that a value that you have set up for yourself as being a heterosexual concept? You need to check your attitudes, make sure they're positive, and be aware of the cultural surroundings. Nurse shows empathy by showing feelings of concern and compassion. I'll remove myself here. Feelings of concern and compassion. So that should be false. It's what the client perceives. Okay, you can show all the concern and compassion you want to, but if they perceive that you are not um, being genuine, or if they perceive that you are being too involved in their relationship or their problem, they're not going to interact with you in a very basic level. So, therapeutic use of self. Nurses and psych do not use a lot of tools of the trade like IVs and things like that. We use ourselves. So, everything you have, your personality, your experiences, your intelligence, this was all come out by Hildegard Peplau. She said that we have a lot of roles that we fit into, and we've already discussed those, to help our patients become a better person. Um, yep. The Johari window is a concept. It's a tool. It's in the book. You can use it to learn about yourself. There's 4 quadrants to it, including the public self, things that you have hidden, things that are private that you don't show other people, and then the unknown, what you don't know about yourself, and the things that you are that are just unknown. So the goal is to move qualities from 2, 3, and 4 into quadrant 1, which is the public open self. And there's our Johari's window. Okay. There's different ways you know things. There's things that you have preconceptions about or you believe. We also look at things knowing either empirically, which comes from science, personally from life experiences, ethically from moral nursing knowledge, and aesthetically from the art of nursing, which is basically the concepts that we're trying to understand in psychosocial nursing. We are the art of nursing. And then there's the unknowing, which is not know or knowing what you don't know. It's very important that you know what you don't know. So if a client looks sad and you look like something's bothering them, what would that be? Which kind of knowing if you see a patient doing that? It probably would be personal because your personal experiences is with the nonverbals of the down face and the quiet and introspective self. So it'd be personal knowledge that you would know that about a patient. Social relationships are not, and intimate relationships are not what we want in psychiatric nursing. Social relationships you can have out and about with your friends because that's the purpose of it. You share ideas, shift roles, give advice, things like that. Those things are not part of a therapeutic relationship. They're part of a social relationship. And obviously, the intimate relationship is not something that we want you to have with patients, but it's an emotional commitment of two people. I'm sure you've had emotional relationships or intimate relationships. I'm not gonna begrudge that. And then our therapeutic relationship, which is what we want you to have with your patients, where we focus on the patient only. If you're using I statements, that's more of a social relationship and you're not helping anyone. You got to use different communication skills to understand and to garner responses from the patient. Agreeing to be working towards the same goal is a very good thing. And of course, you have to be self-aware. So a social relationship involves communication for the purposes of friendship or task accomplishment. And I would say that is true. Let's see. Yes. We have Peplau, and she's talking about the therapeutic relationship. She said there are 3 phases in the therapeutic relationship. The first one's orientation phase. An orientation phase is where you're getting to know your patient, patient's getting to know you, you're establishing or setting up what you intend to work upon, you're working on that trust issue. And then you get into the working phase where you actually identify what the problems are. And then you try to establish definite interventions, definite goals to achieve whatever you want your patient to achieve. This is the longest part of the relationship, and you do all the work there. And then we already talked about termination, and termination usually starts in the beginning with orientation. You let them know, I'm going to be here for this long. And then our relationship will be over. And you can go back and forth because not everybody is going to trust 100% right off the bat. So you have to give people time. Like I said, that trust relationship is paramount, is the first thing you have to do. And you're not going to do it in a day. It's going to take time. The orientation phase, they meet each other, discuss your roles, the purposes of the relationship, identification of the problems, clarifications of what you intend to work on, and then the contracts, you let them know that HIPAA is in place or what they're sharing with you is very confidential. And then I always advise people not to self-disclose because this is not about you. This is about them. Problem identification during the working phase of the relationship, where the client identifies their problems. And then the exploitation part is where they learn to examine and create goals towards repairing their personal problems, including positive self-image, independence. This is where that transference can happen, is during this point. And we talked about that last week. being something that's really a barrier to the therapeutic communication. So you have to be able to keep your feelings in check. If the patient is triggering you or reminding you of someone, and you have to do your best not to trigger your patient, as, you remind me of my mom or something like those lines. We don't want that to happen with the patient. Termination, I say it's in the beginning, you let them know how long it's going to be there, when the relationship's going to end. Sometimes patients will get angry at the end of the relationship if it's not well defined. They will get very upset. And in those cases, you can go back and you can be like, therapeutically, I see you're really upset with the ending of our relationship. I'd like to talk with you a little bit more about that. So you'll want to invest in that and just see how you can help. Okay, let me see. Oops, I think I'm going the wrong way. There we go, termination. Avoiding behaviors. People who have mental health and mental illness issues often do not have the wherewithal to understand completely different aspects. Like in a relationship with your children, you would probably be able to get very close to them and be in a social distance. The boundaries there are just very, very, very important. And a therapeutic boundary is 3 to 6 feet. So try to stay away from your patients at least that far. Now, if you're having a conversation with someone and that's private, you want to take them someplace that's quiet and at least 4 feet away from everybody else, like the quiet end of a day room. But those boundaries you really, really have to make very rigid for yourself. You don't want to be sympathetic. You want to be empathetic, because if you're sympathetic, that's going to encourage your patient to become more dependent upon you, which is not what we want. We want them to be independent. And we do that through acceptance and unconditional positive regard in engaging with our patients. So there are warning signs of abuse in the nurse-client relationship. You're welcome to look at the box. I don't believe there's any questions on that. If there were, I would let you know. We're kind of going to go over things at the end. So during the working phase, which action would occur? Nurse-client contracts are established. I think that is in the orientation phase. Feelings of loss, that's like termination. Client's feelings are examined. Yes, I think that's it. I think it's D. Yay! Look there. Okay. These are the different roles that Hildegard told us about. The teacher, where we can help them solve problems, give them information. The caregiver is the physical care we give to someone. Advocacy, ensuring the privacy, HIPAA. Being a parent, which we don't want to remind them of their parents, but that in parentis locus, that philosophy, where you're a caregiver, but you're a therapeutic caregiver. So you got to be aware of yourself. You got to realize where you're getting burned out. And it's like patients are very stressful. They will take it right to the edge and you can burn out rather quickly. So if you do journaling, that helps. Go into your own self-help group goes, debriefing. I know at St. Rita's they have huddles, care huddles that they do. They have a cart that comes around and offers snacks and things to the nurses to kind of get them through the day. Some people read. I'm not much of a reader, used to be, but not much of a reader. I am one that does a lot of talking. So a lot of group things. That really is very helpful. But you need to figure out what's helpful for you. Okay, that's chapter 5. Okay. Hang on. 5, I don't want anymore. Say, okay, we're going to go back here. I don't want that either. And back here. Yay, okay, right class this time. Sorry. And we're going to go to modules, and we're going to go to chapter 6. Okay, bring her up. Okay, I'm doing it slowly this time so that I'm not just sitting here talking to you without the right slides up. And hopefully this will be positive for you. Okay, shrink you down, bring Zoom back up. Hello. Share my screen. And I believe this is chapter 6, and we're going to share it. Yes. Okay, we're going to do the slideshow from the beginning. All right, so I think on the first day of class, I encouraged you to print off the therapeutic communications. That's just telling you the identifying names of things. Probably a good idea. I'm going to go through the quiz here and I'm going to see which ones we need to know and be able to recognize. So let's just get through this first. Communication, there's verbal, there's nonverbal. It's how we talk to somebody and how we present ourselves, and we want them to match. Okay. Interpersonal interaction, focus on your client and the need for privacy. We want the goals to meet the standards of patient care. We have psychological standards of patient care. We have ethical nurses, patient care. Just know your scope of practice in the state of Ohio and what the ethics are behind that. The goal of the relationship, it helps us with trust. It helps with the therapeutic relationship, helps to identify what's wrong with the problem or what the problem is from the patient's point of view, helps the patient express emotion. Therapeutic communication teaches self-care skills and the needs of the client, and helps them identify things that they can do to help themselves. Okay. We've talked about the distances, personal, social. It says here 4 to 12, and public 12 to 15. Therapeutic, however, and I'll say it again, is 3 to 6. Might be something good to know. Okay. Social and physical distancing, we've had that with COVID, social distancing, staying at home. That led to a lot of problems with psychopathies in people dealing with other people. So while you need to keep distance so you don't get sick, there are other ways that you can protect yourself. Physical distancing says stay 6 feet away, but that's not going to work for a therapeutic relationship. You're going to be in the outer aspect. So if you're talking to someone, you're going to want to go into their room. You're not going to want to stand at the door. Okay. Distance sense, we talked about that, and the therapeutic use of touch. I usually just tell you guys at this point in your career, as a basic healthcare provider, a basic nurse, a registered nurse, I wouldn't touch anybody. Even therapeutic touch can be misconstrued in this population. So, if you feel a need to reach out and offer some healing, try to limit it to hands, maybe shoulders. That would be the safest. So if you're feeling very empathetic and you want to convey that in a nonverbal way, try to stay to the safe areas, which cannot be misconstrued. Even the shoulders could be, the hands could be. But if you do it, while stating that you feel sorry, that you're something along those lines, which is empathetic, rather than sympathetic, they will understand. Touch, lots of different types of touch. We just talked about that. There is functional, there is social, friendship, love, and sexual. And again, for these types of patients, just not a good idea to touch them because you don't know their preferences right off the bat. You don't know their history, their needs. You just want to be you want to be supportive, you want to be empathetic, It's going to be based upon what you are feeling, but with an understanding that this population misunderstands a lot. So a distance of 2 feet between the nurse and the patient is most appropriate for therapeutic communication. Nope, 3 to 6. Some different communication things that we do. We need to have active listening, active observation. So we're looking at our patient and we're seeing that their verbals and nonverbals match. And we're looking and listening to exactly what the patient is saying to get an understanding of it. They help us recognize what's important, what further questions we need to ask, prevent us and your patient from jumping to some pretty bad conclusions, and it helps you respond to the patient's messages. A lot of times patients in crises will need to have concrete messages, which means they are exactly, go sit in the blue chair, and you point to a blue chair. That's a very concrete message. Some of the techniques that have been named is exploring, focusing, restating, reflecting. They're all in that sheet that I put up on Canvas for you. They help the patient talk. Focusing, really you need to address a topic before you can focus on the topic. So you're not going to want to jump in if the patient's talking about their dad and say something along the lines of, tell me how your dad abused you. You don't want to do that. So you want to clarify their relationship with their father first. And then looking at what they're looking at and listening to what they're listening to. And if it is not congruent with what's going on, inquiring without feeding into it. So someone's hearing voices, you make a statement along the lines of, you seem to be hearing voices that are not there. And that's called presenting a reality. We do want to avoid non-therapeutic techniques such as advising someone. You do that in social, but not therapeutic. Challenging, probing, reassuring. Nurses do this all the time. Oh, it's going to be just fine. Yeah, no, that's not therapeutic. And then we need to interpret some of the things that they may say. Overtly, they may say, yes, I'm going to kill myself. Or they may say covertly, the world would be better off without me. So, and then you inquire, what do you mean by that? Tell me more, because you want to clarify, are they suicidal or not? Your faces, your body language, theirs, all of this is speaking volumes. So, some people are very expressive and congruent. Some people are not. Some people have confused, they're laughing and they're saying, oh, and then, I hit him in the back of the head with a baseball bat. That's incongruent. They shouldn't be happy about that. And then we have closed body posture, which is pretty much wrapping yourself up and not letting anybody near you, and an open body posture, which you want to have when you're talking with your patient. There are vocal cues, eye contact, and silence. These are nonverbal communication techniques. Vocal cues would be a pause, and then they would elaborate more. Silence is something that you can use in your arsenal. It's very, very, very effective. When your patient uses it, that's telling you that that's something they want to talk about. The way that they look at you, if they're not looking at you, if they have avoidant gaze, it's probably something they don't feel ready to trust you with. But when someone is looking at you and having conversation, that is a clear identification of trust. So, it's following statement true or false? Nonverbal communication is often less accurate than verbal. Haha. No. People can't stop their nonverbal. It's actually more accurate than verbal. People lie. Okay. Understanding meaning, context, and spirituality. The meaning of a message is often more than just what's spoken. If you see someone talking and you see them tear up, they're having an emotional response to what they're saying. So it's telling you a little bit more. The contextual portion of communication is validation of the client's findings from verbal to nonverbal. So if you see them doing that, you can state something along the lines, I see this topic is really hard for you. And that's like validating their feelings. And then we need to focus, again, concrete on the who, what, when, where, how, and why, but don't ever use the word why. Spirituality, you got to think about yourself. If you are a spiritual person, are you comfortable with someone who's atheist? If you are someone who is Buddhist, are you comfortable with somebody who's a Catholic? How they believe about their life and their spiritual needs and death could be, and often is, different than the way you see things. So that's where that unconditional positive regard and genuineness for concern of their feelings. So you need to be aware of yourself in order to be respectful and to have a good therapeutic relationship. Culturally, translators are good. You do want to have a translator if someone has a different language, but the way that we have inflections in our English language can mean something different as far as a direct translation to the patient. When you say something, English is a hard language. When you say something in like, how did you feel about that? Well, the patient may think, what is she asking me? How did I touch that? Because I don't understand that. So the word feel is kind of ambiguous. So you just kind of need to understand not everybody is comfortable with the language or the inflection or the idioms. That's a big one for English languages, or how people communicate. So shaking hands, some cultures do not shake hands. They won't shake with the left hand because it's dirty. They will shake with the right hand. You just have to look at the culture and appreciate the differences. And understand the differences. Like yesterday, I was getting my hair done, and a woman came in a full hijab, and they got privacy curtains surrounding the beautician's chair for her to get her hair trimmed. Her husband was there. He stayed with her. And I approached because I wanted to give a tip to my beautician who was beside this person, and the one who was cutting the hair of the woman in the job, she stepped right up and said, "This is a privacy area. You cannot come in this area." And I said, "I'm sorry, I'm going to this area over here." I just kind of took a turnaround chair. So they're very serious, different professions, but she understood that regarding that patient and that patient's need for privacy when her hair was exposed. So you have to understand those differences, I guess, is just the easiest way to say it. Which of the following is non-therapeutic? Reassuring, reflecting, focusing, or exploring? I think it's reassuring. Ha, yeah, because it's attempting to dispel how they feel. Okay. Oh, it's going to be okay. It'll be fine. That doesn't validate how they're feeling about the situation. Goals. Um, Goals are very important. The helps if you are listening to someone, helping them decide what they want to establish as a goal. Your job is to use the therapeutic communication techniques to help them explore how they're feeling really and establish barriers and a guide or an outline related to what they want to do to help themselves. Therapeutic session. Well, it needs to be someplace private. You do an introduction of yourself. Hello, I'm Jackie Martz. I'm going to be your nurse today. I'm going to be here until 3 o'clock. That's when we will end our relationship for today. How do you like to be addressed? So some people like to be used their first name. Some people like to have you call them Mr. or Miss. Some people have the designation of doctor. They prefer that. So You do need to know that when you are addressing someone, you need to address them according to their preference. You're going to use a lot of open-ended questions, broad openings, things like that encourage people to talk, which they should be talking way more than you. Okay. And then you can ask some yes, no questions. Usually, if I'm asking a yes, no question, it's going to be related to, are you thinking of killing yourself? So suicidal ideation, we don't want to give them lots of room to talk about that. We want to know their intention right away. Okay. Open-ended versus yes, no questions. It's more therapeutic to use the open-ended questions. You can use the yes, no questions, but I would reserve those for more serious danger conversations. Sometimes it takes you a minute on how to rephrase what you want to say to a patient. So that requires that you think and not feel, oh, that's terrible. I feel bad for you. You want to think about how it feels for them. Okay. Clarification, placing an event and time of sequence. Those are all good kind of broad questions that you can ask. What do you mean by that? Or did you walk down the stairs before or after your husband came home? Things like that. That's placing it in a time or sequence. Asking for clarification often helps, avoid that miscommunication in what they're trying to say to you. And if they are unable to translate what they're feeling into words, that causes a lot of anxiety. And if we use open communication, it allows people to breathe and to address the topic in their own time through their own words. Okay. So no putting in your own belief system either. Positive or negative feelings or ideas, common. This is assertive communication. The I statements. When you talk over me, I feel upset. I feel angry. Okay. Sometimes you're going to get some various responses back from people that you're communicating with. When somebody says that, they could be very, aggressive. They don't like that language. Or they could be passive aggressive. Oh, yeah, I agree with you, but not really, because my nonverbals are saying no. Or very passive. Passive language is just kind of you roll right over top of them, and that's not, oh, I agree with everything you want to do and say, and that's just not therapeutic either. But you do need to be assertive, and you need to help your patients understand how to be assertive in their communication, because that passive aggressive or that passive or the aggressive individually for your patients are often triggers for other people. So you need to help them be assertive. Sometimes this is the broken record technique. That is a person who practices and practices and practices what they're going to say before they say it. Lots of people will do this. Like I've been in situations where I have to go talk to um, a friend of mine, or I need to go talk to a boss I want to raise or something like that. Practice what you're going to say and how you're going to say it before you enter into this situation so you feel more comfortable. And that will work for your patients also. It's quite well. Community-based care, we have a lot of higher needs for community. Therapeutic communication is important in the community, how we talk and treat each other. It helps us become more self-aware. Okay. Okay. And that is chapter 6. We're going to stop the show and we'll get up chapter 7. Okay, so back again, ready for that last chapter. So let's pull that up. Does that hand go here? Modules. Chapter 7. Oops, went too fast. Chapter 7. Client's response to illness. Okay. And we're going to share the screen. Share the screen. Haha. Client's response to illness. Chapter 7. Slideshow. Okay, here we go. So individual factors or how people respond to being sick depends on their age, their growth and development, which is why you take that class. Erickson talks a little bit about each stage of development. And I know I mentioned in class previously that your personality disorders come from unresolved growth and development, Erickson stages. And you're welcome to look at table 7.2. Different things affect different people genetically. Schizophrenia has genetic markers. Depression has genetic markers, as does bipolar disorder. So the healthier physically you are, the belief is the tendency is that you have better ability to cope. If you take medications, so for depression or things like that, it's going to be the way it's going to work is dependent upon your genetics, basically. So, how you believe about yourself? What do you believe about yourself? Are you efficacious? Can you survive? I'm a survivor. So, how hardy are you? So, how much of a control are you in? How much commitment do you have? Your resiliency, how quick do you bounce back? Kids are very resilient, like in abuse situations, they still have that capacity to love. And then spirituality. So what do you believe? What do your patients believe? We've already talked about the value. Do you fit in anywhere? Do you belong? That is an undercurrent that really is something that people need. People need to belong to something. They need to perceive they have a support system of some kind. Culturally, we've talked a little bit about that. You can look at the box for cultural humility. Communicative factors for cultural assessment, not just the language barrier, but the verbal and nonverbal and congruence. The social organization, so the hijab woman, the woman with the hijab on, getting her hair done, that convention, I understood that, why she needed privacy for that. Time orientation. There are some cultures that are believed to be chronically late. They never make it to an appointment on time. It's just a belief. And then there are biological variations in certain people. They could have, for depression, say, not enough receptor sites because of a genetic influence there. Social determinants of health. We've already spoke about 20, 30 healthy people, increasing healthcare access and education. Health literacy is how well people understand their health. So if someone believes, I ran into this a lot with diabetes, if they believe their father had diabetes, their mother had diabetes, their mother had a heart attack and their father had an amputation, they will have a heart attack and they will have an amputation because that's what they believe. And it's very hard to change somebody's belief system just because it happened to mom and dad. It doesn't have to happen to you if you control your numbers. So diversity, this is a starting point. So when you understand diversity, it's kind of a starting point of taking care of people. So is the statement true or false? Cultural factors affect hardiness and resilience. It is false. So those are hardiness and resilience are based upon who the person is. That's your individual factors. A nursing role dealing with cultural diversity, seeking knowledge about the other person's culture. If you don't understand that some people don't shake with their left hand, you need to go study and read up on that. You need to ask what their belief system is. You need to be very open about understanding somebody else's differences. And then you got to be aware of yourself. Okay. Sometimes you can have cultural bias, and that's not good. All right. So I think we're ready to go and look at the quiz now. I'm going to stop sharing my screen. Okay, we're gonna take a look here. And I'll tell you what you need to know. Boundaries. How people know things. Munhall, he's a theorist. So look at Munhall. Therapeutic relationships, what is appropriate to establish it and maintain it. Yeah, the resistance at discharge, they get angry at you. Covert messages. All those non-therapeutic methods. We don't give advice, so some of the non-therapeutic message. Therapeutic distance. Talking with the patient in a crowded room. Then you have to order how to problem solve or help your patient problem solve. Other non-therapeutic technique you should not use. Therapeutic technique to get them to talk to you. Cultural consideration. Being aware of yourself. Empathy versus sympathy. Cultural consideration again. Group therapy. Oh, schizophrenia. Group therapy for schizophrenics and prognosis. How do you know your education for a patient has been effective? Alprazolam. You need to know that med, alprazolam. Hardiness, resilience, tolerance, those definitions. Mind perception. And culturally competent care. All right, guys, that's pretty much our quiz. So take a look at the chapters, read through them, really focus in or hone in on the therapeutic techniques and non-therapeutic techniques. Those definitions I told you about, definitely the medication, and we'll see how you do on Tuesday. Happy studying. I will see you then.